Hello, everyone. Again, my name is Carol Osborne. I'm here with Dr. Murray Riker, and we are here to present the eHR version 2.0 training for the 24 edition of Meaningful Use. And also feel free to enter in your questions through the Q&A box throughout the presentation, and we'll get to the questions and answer at the end of the presentation. Today's agenda is to go over the 2014 changes to Stage 1 and Stage 2 requirements, and also the changes that DR made to the softwares in terms of what the eHR administrator needs to be aware of for setup and compliance purposes, and any data entry changes that you need to inform your staff, or any workflow changes. At the end, we'll also go over some of the key action items and review the key action items to make sure that you are aware of the things that need to be done. Now, if you are an eligible professional that started in the year 2013 last year, or are planning or is planning to start in 2014, you will still be on Stage 1 this year. There are a couple changes, very few changes to Stage 1 rules this year for core and menu set items. There's an update to exclusion criteria for vital sign, where in the past an EP can exclude the vital sign measure if all three vital signs of height, length, and weight, and blood pressure is not relevant to the scope of their practice. There are two additional exclusion criteria in the 2014 version, and that is if height and weight is relevant to your practice but not blood pressure, then you still need to record height and weight, but you are excluded from recording blood pressure. Vice versa, if blood pressure is relevant to the scope of your practice but height and weight is not, then you can exclude from collecting height and weight. There's also an update to the CPOE for medication, how the denominator works. You have the option to record by patient or by medication orders for the CPOE measure. Now,
this is Murray Riker. I also want to welcome you today, and I'll be interjecting comments from time to time. So with regard to the Stage 1 measures, the thing that I'll really add to what Carol just mentioned is that I don't expect either of these changes in the core criteria to affect either our radiology or anesthesia users. We want to be complete and let you know what all the changes are, but these are not changes that are likely to affect you. I think the radiologists that are mostly excluding vital signs today will continue to do that. There may be a few that decide to collect blood pressure only, and that's okay now. You don't have to do blood pressure, height, and weight. And the subtle change in the way CPOE works for medications probably won't affect any of you.
Okay. And the next measure, previously providing electronic copies and electronic access is now replaced with providing patients to have the ability to view, download, or transmit their health information within 4 business days. And this is completed via using Health Companion. There's also one measure that has been dropped, and that's the electronic exchange of key clinical information here. In the menu set item, the big change is now that providers cannot select a menu objective and claim exclusion if there are other menu objectives that they meet first. And the other change is public health reporting objective now requires an electronic exchange. On to Stage 2 changes and requirements. If your EP started in the year 2012 and they completed both 2012 and 2013, they will be on Stage 2 requirements this year. There are quite a few changes here. There are threshold increases for many of the measures. There are 2 new patient engagement measures. You are required to have more than 5 of your patients view, download, and transmit their health record data, and that more than 5% of your patients send you a secure message. And this is also met using Health Companion, the patient portal, and the provider portal. So you definitely want to encourage your patient to log into Health Companion, send you messages, and stay connected with your practice. There are some updated measures. Clinical summary, you now have to provide your patient with access to clinical summary within 1 business day instead of 3 business days. DR launched a new feature last year called the automated sending of EOE, end of exam, and if you utilize this feature, it'll ensure you to that your clinical summary are sent to Health Companion for your patient's access within 24 hours. You can set to have the EOE sent 5 hours after the exam is over, 6 hours, and so this is a really good feature for you to turn on if you haven't already. Again, the exclusion criteria for vital sign also applies here, as mentioned in stage 1. And additionally, there are 5 clinical decision support rules that are required instead of 1. This is also enabled or provided to you by default with the software, so there's nothing you have to do for the clinical decision support rule. There are additional core measure items that moved up from menu set item, and those are incorporate lab test results, generate patient list, reminders, patient education, and also medication reconciliation. In the menu set items, there are 3 new measures. The first one is record electronic notes for your patient record, to have at least 1 electronic note. And also you need to be collecting at least 20% from your patient on their family history, either first degree or if they don't know any, then you can put an unknown. And the third one is more than 10% of image result is available in the certified eHR technology, and this applies to the ordering physicians only.
So this is Murray again. Let me recap a few key points here. One is probably the area that I get the most questions in is the area of secure messaging. And this has been a controversial area even with CMS. Doctor groups have said, seriously, we're going to be on the hook to be sure that our patients actually message us. That's not something we can control. And the CMS response has been, yes, it is. If you provide your patient even the most rudimentary capability of messaging you, we know from wide clinical experience with EMRs that patients will take advantage of it. So when you look at the stage 2 requirements, we've built in a lot of technologies to make this work pretty seamlessly. So for example, if a patient logs on to Health Companion to view their CCD, if they log on to Health Companion to pre-register for an appointment, or if they log on to Health Companion to view a radiology result, such as a report or a lay letter, which we're enabling some capability for those of you that are interested to do that as an option. They do any of those 3 things, or if they actually send a secure message through Health Companion, which they can do, in any of those instances, you'll get credit. An automated secure message will be sent back, for example, if the patient simply logs on to Health Companion and registers. And so if you can get 5% of your patients to register for Health Companion, you'll meet the 5% secure messaging criteria. And then with regard to both stage 1 and stage 2, I just want to reiterate that exclusions no longer count in your favor. So you want to look for the menu set items that you can actually accomplish, not exclude from. In a way, they kind of still might count in your favor. So for example, if you can only accomplish 4 of 10 menu set items in stage 1, or 2 of the 6 menu set items in stage 2, that's still okay. But you want to first look for the ones that you can not exclude from and do those. One of them in stage 2 is the recording of electronic notes, and we have an automated system to handle that today, so a doctor doesn't actually have to type in a note. When the smoking status is recorded, it automatically generates a smoking status visit note. We'll cover that in greater detail in a minute. You are going to want to have at least one item of family history recorded, so that is one small additional step on the health status screen. And the patient can record family history via Health Companion if they pre-register. And the third bullet point you see here, the making radiology results available in a certified eHR, is not one that really affects you if you're a radiologist or anesthesiologist, in that you don't generally order more than 100 imaging studies a year, but you're the one that may be doing them if you're a radiologist, so you're going to exclude from that one. However, it's one that you need to be aware of, because if you're in the radiology world, your referring doctors are going to care about that one when they refer patients to you. They're going to need to have images available to them in at least 10% of the cases where they refer a case to you for imaging. And there are other technologies within DRSYSTEMS like eMix and our Zero Download Ambassador that can help you with that.
Okay, so now on to the clinical quality measures. In 2014, clinical quality measure is no longer a core objective requirement. It's now a standalone requirement. They must be submitted electronically and also reported 3 months of data for this year. DRSYSTEMS supports 9 clinical quality measures selected from 3 of the 6 domains that are listed here. And previously, providers would have to complete a CQM questionnaire in order for the CQM data to be calculated. This is no longer required, and also we have a user guide with a list of relevant CPT and SNOMED CT codes that will be available to you for you to figure out if the CQM and the CPT and SNOMED codes apply to your practice.
Yeah, so to recap again on this one, we've really simplified compliance with the CQMs. Again, I think most of our users are going to end up reporting zeros for numerators and denominators for the CQMs. But as before, our user guide will provide you a list of all of the relevant CPT and now SNOMED codes that might trigger a CQM requirement and a denominator. And even in those cases where a denominator is going to be counted because you're using a particular CPT or SNOMED code, the numerator is now calculated based on information put into the medical record, either via visit notes or in some cases immunizations or problem lists, and no longer requires you to fill out a questionnaire.
Now on to the changes for setup that an eHR administrator should be aware of. So under administration, we have 2 new sections, a meaningful use setting and also personal health record setting. We put in a new face-to-face feature that allows you to count the exams specifically for meaningful use purpose. And by default, when we upgrade the software at the end of this month, all exams that come through interfaces and that are either come through interfaces or created manually will count towards meaningful use purpose unless you go into the organizational setting and deselect it yourself. So there are two ways of doing this. You can either by default count all exams, and then on the individual exams that does not need to be counted, go back to the individual exams and deselect those exams. Or by default, not count any of the exams and then go back to the individual exam and count the ones you want. Under personal health record setting, by default, all data coming from Health Companion will be automatically reconciled unless you deselect them here. And this is only if this is applicable for sites that have pre-registration appointment or email turned on. The other feature I want to mention here is the automatically send clinical summary to the personal health record system at a certain hour after the last visit. And this is the feature that will help you ensure that your EOE will get sent within one business day for a patient to access it on Health Companion. So if you don't have it turned on already, you should consider it.
Yeah. So 2 key points again to recap. Number one, we really have a feature that I think is kind of a game changer here, and that is this ability for a physician, when they actually see a patient, to count that visit for meaningful use. Yet for you to run all of your visits through the DREHR for the benefit of patient engagement, added clinical information, yet not have the full administrative burden of complying in all of those visits that you don't count with the meaningful use data gathering and reporting requirements. So I'm guessing that for our radiologists that are using this system, most of them will want to run all of their visits through our system for the many clinical and patient engagement benefits, but only manually check a box when they want to actually count a visit for the accounting purposes of meaningful use. And then one last recap, if you're not already using the automated EOE, that checkbox at the bottom of the screen, I'd really urge you to do it, because as the delivery timeliness requirement goes down to 1 business day, I think it's going to be very tricky for organizations to succeed without having the clinical summary and EOE sent out automatically the day of the patient's visit.
Now, under eligible professional, you want to make sure for all your EP, you go to their setting and put in the year stage 1 that they started in. This will make sure when you go to automated measure calculator to calculate the EP's performance, that it counts the right stage that the EP's in. So for example, this physician started stage 1 in 2013, so for him in 2014 he will still be on stage 1. Now underneath you'll also see access to provider portal, checked by default. This is access to the Health Companion provider portal for the physician so that he or she can access Health Companion or secure messages sent from patient's Health Companion. Below that, you'll see associated user. Now, many times a staff will access on behalf of physician or use eHR, manage eHR on physician's behalf. And so you can associate your staff to each physician so that the staff can respond and read the messages for the physician as well. Now, vice versa, under users group in administration, you can associate an EP to a user instead. So you can do it both ways. You can either associate a user to an EP in this previous screen, or you can associate an EP to a user here. Now, how does one actually access secure messages via Health Companion provider portal? On the home page, you will see a Health Companion button on the navigation bar to the right side. Whenever there's a message waiting for you, you'll see a Health Companion button blink. And by clicking on it, it'll launch a single sign-on browser to take you to the provider portal. And here you can access many things, the patient's report card, messages, contact information, other measure calculation. And under messaging, you'll see the messages that you receive from your patient. You can also compose messages to send to your patient as well.
Yeah. So basically, you can use the eHR in conjunction with the Health Companion provider portal that is synchronously launched within the eHR for users that have the appropriate rights to do a few things. Well, actually to do many things, but 2 things that are relevant to this discussion. Number 1, you can message individual patients and receive messages from them. Number 2, you can also message your patients as a group. And the game here is You get as many patients as you can to log into Health Companion and become registered users. And now you have a secure methodology for communicating for marketing and education purposes to all of the patients that have ever seen you that have gone into Health Companion. So if you have a new technology or new doctor, or you're trying to boost mammography or DEXA or ultrasound or lung cancer screening compliance, you can message all of your patients, and you can also send and receive messages to individuals.
Now on to the compliance section. We've made a few changes here as well. In the non-compliance report, we've updated the layout to include family history and then also clean up the layout. You would use it as you have before. You put in visit date, range, select the eligible providers you want to generate a report for, the criteria, and you can generate a report that way. Or you can view today's report, view yesterday's, and 3 business days ago. Under compliance, for the automated measure calculator, there's a new feature where you now can generate an all EP report. We've had feedback from many different sites that want to have a way to view their EP performance as a whole. And so what this provides you is you can select generate an all EP report by date range, and it'll show you a report for EPs that are stage 1, that are stage 2, and also list out all the criteria. And the compliance note is color-coded. So anything that's in red means the EP did not meet compliance for that specific rule, but anything in blue means he or she has met that requirement. For the individual EP report, as I mentioned earlier, you definitely want to make sure you set the EP's year that he or she started stage 1 in, and therefore it'll generate the right stage report accordingly. So for this physician, Dr. Hook, during this date range, he is reporting for stage 2, year 2. And the report will generate a stage 2 report based on the data that he has. And we also redesigned the selection box to the left side here so that it'll remember the selections that you checked the next time you come back. And so you can remember that the physician examined for a couple of these measures, and also you want to print for some of these measures, so you can utilize the checkboxes here.
Yeah. So for many of you that have organizations with lots of physicians in them, you might have one physician in stage 2, year 1. You might have another physician in stage 1, year 2, and a physician that just joined your group this year that's in stage 1, year 1. By configuring each physician's year based on when they started in the program, the system will automatically, as you select the physician, bring up the right report, whether it's a stage 1 report or a stage 2 report.
Now onto the data entry changes. There are a few changes here. As you can see on the create patient / demographic section, you now can, or the patient can now provide you multiple race that's applicable to them, and so you have to be able to check multiple race. Or if they continue to decline, then you have that selection as well. For preferred language, you'll see a more comprehensive list of options. We've listed the top 9 most commonly used language in the according to U.S. Census, and there are a lot more selections down here. For create exam, you'll see on the individual exams the option to select or deselect count for meaningful use purpose up on the top left, as well as we've updated the selection down below, whether you want to include the visit information in the summary, or if you want to exclude certain visit note sections from the summary, you can do that as well. Now, if you're a physician and you want to access eHR from the DR Unity, you can do so via the eHR tab in Unity. And if the physician is monitoring or managing counting of meaningful use himself or herself, then they can select or deselect count for meaningful use box here.
Yeah, so this is really a very key point. If a physician is reading exams in Unity and they're one of these physicians that by policy is only counting face-to-face encounters for meaningful use purposes, but you have an upstream interface or through some other mechanism, even manually, you're bringing all of the exams through eHR because maybe you want to send all patients their letters or results, or you want to have them all available for marketing purposes, through this electronic connection. That's fine. In that case, a physician who is only going to count face-to-face encounters would depend on a site administrator, first of all, setting the system so that only the face-to-face encounters are counted. And when they see a patient face-to-face and they're reading that patient's exam, they'll come to this page and click one box in order to tell the system, this is a visit that we're going to count. For those of you who are not using Unity, obviously the doctor can access this same page via a standalone application on a PC in order to check that box as well.
On the health status page, there are also a couple of changes. Again, you can see the count for meaningful use checkbox here for each visit. That your staff can make their selection here if need to. And on the smoking status section, there are 2 more smoking status choices. And you'll see a SNOMED CT code listed next to it. And by updating or entering the smoking status for the patient and clicking Save, it'll generate a visit note recording in the visit note section that I'll get to in the next slide. And there's also a new section on family history, and this is where you can add family history data for the patient. So if you select a visit and update patient's smoking status, a visit note will be automatically generated for that smoking status in the patient's record. Depending on whether a patient is a smoker, the message will apply, will show according to patient smoking status. So if the patient is a smoker, the message would be cigarette smoking is the leading preventable cause of death in the United States. Learn more here.
And that's designed to be an automated benefit for you. Doctors probably, at least in the radiology arena, don't want to manually enter notes. And this way, if the smoking status is recorded and your staff clicks Save for every visit, even if the smoking status has not changed, the visit note will be associated with the visit automatically, and your doctors, your EPs, will comply with the requirement to have a recorded visit note.
And we've also redesigned the meaningful use checklist that many of you use or see at the bottom of the list here. You now will see anything that requires an action that shows you a red indication of required. Anything that's in compliance, it'll show you the number of days when it was updated, and also a green check mark. And we've also added in family history as well as reconciliation. The key action item, let's review all the sections that we've just gone through. For an eHR administrator, you definitely want to make sure you check the meaningful use and health companion setting under administration. by default, you will have count for meaningful use checked, count all exams for meaningful use checked unless you de-checked it by default, and also check to see if your automated EOE feature is on. Number 2, you want to make sure you configure each EP for the proper meaningful use year. Also set up the secure messaging feature so that you can receive messages from your patient. Next is a lot of our sites, or a lot of radiologists, take the approach of face-to-face seeing by policy, and so you definitely want to make sure you have documentation that details the process that your practice goes by for the seeing by. And then next, you want to determine if relevant CPT codes and SNOMED CT codes apply for collecting CQM data. And number 6, you will need to, or continue to do an annual security risk analysis every year.
So let me recap a little bit and just be sure that we drive these key points home. In about 10 days or so, we'll be upgrading our system, and at that time, it's really important that all of the site administrators take note and make some changes. Number 1, this is the time to decide. If you're one of these practices, like many of them, where all of the exams are counted for meaningful use purposes, great. No changes required. That box is going to be checked for your site just like it is today, before the checkbox existed. If, however, you decide you only want to count the face-to-face visits for meaningful use purposes, yet run all of your visits through MU, through the DREHR for all of its other benefits, you can do that. Just make sure that you deselect the Count for MU box on the site administration page. Next, be certain that you have that auto EOE feature checked. DRSYSTEMS does not check it by default. We highly recommend it. We don't force sites to do it, but we think it's greatly beneficial for compliance. So please strongly consider enabling that feature. Make sure that you configure each EP so that the system knows what year they're in terms of meaningful use compliance. And of course, add any EPs that you're adding for this year. For the secure messaging, I just doubt that hardly any radiologists are going to want to be the ones that respond to any messages. So it's important that you set up for each physician one or more administrative personnel links who will be responsible for responding to secure messages. A patient may respond back to you and say, my CCD or my clinical summary says I weigh 270 pounds. I actually weigh 170 pounds. That is probably not a message that your doctor needs to or wants to respond to. If you are going to use the face-to-face criteria to count an exam for meaningful use, and there's more information available on this in our user guide, but if you are going to do that, write a policy. The policy can be different for each EP in your practice. However, it does need to be a logical policy, and each EP needs to adhere to his or her policy consistently throughout the reporting period. Take a look at the spreadsheet that we'll be soon making available so that you know the full list of CPT and SNOMED CT codes that are relevant to collecting CQM information. When you use one of these codes, and I'm going to guess that hardly any of our EPs ever use any of these codes, but if you use one of these codes for some reason, it does need to be manually entered when the relevant procedure is performed. A CQM denominator will be created, and if you want to accurately collect information on the numerator, you'll have an opportunity to do that based on the medical record that you create. And don't forget, every year, whether it's really the DR eHR or all of your systems from DR, but particularly for the eHR where it's required by meaningful use, you should conduct an annual security risk analysis, document it, and file it. You may be asked to produce it during an audit. Now let's go over some of the workflow changes. If you are going to use the face-to-face method, you're going to have to train your physicians to check the MU box, or if it's not a physician, somebody else. It's probably easiest to simply train the physician. If they're seeing a patient face-to-face, they're the ones that know that they have done so. By the way, your policy can exclude incidental encounters. So, for example, you could have a policy that says when a doctor does a breast biopsy, he or she counts that as a face-to-face visit, but when they start an ID and CT, they don't have to. That's okay, as long as you adhere to the policy. But someone's going to have to check that box, and it seems to me that the person who knows that they've seen the patient is the doctor. And besides, if the doctor, when checking that box, will leave a note for the patient that says, you know, thanks for coming in, or look for these problems, it's a way to engage your patient. It satisfies the visit note criteria as well. And it gives the patient a reason to log on to Health Companion. And you have every motive to have them do that because, number one, you need 5% of your patients to satisfy the secure messaging criteria, and logging on to Health Companion does that. And in addition to that, it really is a way to engage your patients. And when they enroll with Health Companion, they then have this link to your practice so that you can use the DR eHR as a marketing tool. Remember that there's this new all EP compliance report. A lot of our users have asked for it. So it's the equivalent of a spreadsheet that at a glance will let you see all of your EPs, all of the measures, and their level of compliance. And again, remember that when your patient is leaving your facility, you're going to have to give them a handout that educates them about the use of Health Companion, and that handout must contain a PIN if that patient has not yet set up a link between their Health Companion account and your account. If they have already set up the link, they won't need the PIN, but there's really no harm done in giving every patient a handout with the PIN, whether they've been there at your practice before or not. So I think that wraps it up for us. Thank you so much for attending today's meeting. I hope you found that it's been helpful. We'd love to get your feedback. If you think it hasn't been helpful or there's a format that we can use that would be more helpful, certainly let us know. We've tried hard to invent a system here that satisfies your need to be compliant, to engage your patients, to install infrastructure that enables you to better communicate with referring doctors and outside hospitals, to keep you up with the ever-evolving standards in healthcare, and to do so in a profitable and efficient manner that actually helps radiologists and anesthesiologists that are round pegs fit into the kind of square hole that is the eHR incentive program, while still taking advantage of, as I said, of all the patient engagement and added clinical information benefits that we've all been striving to achieve. If you have any other questions, please email us. You can email support questions to drsupport@drsys.com. And I'm guessing that everybody here on the line also knows my personal email address because I've gotten emails from all of you. And I thank you for those, and Carol Osborne's email address as well. So thanks very much. Have a wonderful day.
Thank you, everyone.
Bye-bye.